Thank you, Suzanne, and for the next 2 hours, I will tell you about immunotherapy, since Paul gave me all these assignments. It's really great. Anyway, current and emerging immunotherapies for myeloma. As you heard, immunomodulatory agents really were the first treatments, immunotherapies for myeloma. Then came these monoclonal antibodies, Elotuzumab and Daratumumab. And now we have some really interesting investigational agents, such as the antibody drug conjugates, the CAR-T cells, and the bispecific monoclonal antibodies. Let's start off with monoclonal antibodies. Elotuzumab, the anti-SLAMF7/CS1 directed monoclonal antibody, Daratumumab, the anti-CD38 monoclonal antibody, and then you heard a bit about checkpoint inhibitors. Let's start with the checkpoint inhibitors. Really promising data suggesting that maybe as single agents they're not doing much in myeloma, but when you add it to immunomodulatory agents in relapsed and refractory setting, we saw some really nice preliminary data, yet comparative trials, both with Pembro-Pom-Dex or Pembro-Lendex, have suggested an inferior survival for patients over the standard of care, and with increased toxicity. So very a cautionary note. There are studies ongoing to combine these medications, but for the moment, we have to be cautious about using them. Elotuzumab, the anti-SLAMF7 and CS1 monoclonal antibody, seems to promote killing of multiple myeloma, not through a direct toxic effect like Daratumumab, but NK cell-mediated antibody-dependent cellular toxicity or direct NK cell activation. And you know the ELOQUENT-2 study, the study of that compared in 1 to 3 prior regimens, lenalidomide and dexamethasone versus elotuzumab, lenalidomide and dexamethasone, and showed a significant improvement in progression-free survival, albeit a median of about 4 months, and an increase in the response rate when the combination of elotuzumab to lenalidomide and dexamethasone was used in this setting, with minimal infusion-related toxicity, though some, I guess, signal for an increase in infections, particularly zoster, and some more lymphopenia. Daratumumab has multiple mechanisms of actions, including the immune-mediated activity, direct anti-tumor effect, and immunomodulation, and as you've heard, it's really been a tremendous addition to our treatment for myeloma. In the Gemini twin studies of POLLUX and CASTOR, the first one using the immunomodulatory agent lenalidomide, Dara-Lendex versus Lendex, a tremendous improvement in the 1 to 3 prior regimen setting, using the monoclonal antibody, a tremendous improvement in progression-free survival, with a tremendously reduced hazard ratio. But as Paul indicated, there's an emerging evidence that there really is some increase in infection risk when we're adding these monoclonal antibodies. You can see there was a 39% grade 3 or 4 infection in this updated report from ASH 2017. In the DRD versus the RD, there fortunately was no increase in second primary malignancies. So I think our awareness that when we're using these monoclonal antibodies to watch closely for infections and to prophylax for infections, particularly in the first couple of cycles of the treatment, is very important. In the CASTOR trial, again, we saw tremendous also improvement in progression-free survival, and with the combination of daratumumab bortezomib and dexamethasone versus bortezomib and dexamethasone. Again, some mild increase in toxicity when adding the daratumumab with perhaps some question of a bit more infections, but still the tremendous improvement in progression-free survival. And as you've heard, because of this tremendously positive data, the incorporation of the monoclonal antibodies right up front is now being tested, and perhaps something like daratumumab KRD will become the R-CHOP for multiple myeloma. And in this small early pilot study, though, very well tolerated in terms of toxicity, and tremendous response rates, 100% response rates with Dara KRD. 91% of the patients ultimately had a greater than or equal to VGPR, 43% of the patients going into complete remission. So very, very impressive initial data. And in terms of toxicity, most of the toxicities that were seen were related to the carfilzomib, lenalidomide, and dexamethasone more so than the daratumumab. And fortunately, there was no a worsening of cardiotoxicity or something like that. So very promising data incorporating these monoclonal antibodies into initial therapy. Now, of course, one of the major downsides of daratumumab is the long infusion, and what is very encouraging is the subcutaneous data that we're seeing with daratumumab, and presented 2 years ago was subcutaneous infusions using syringe pumps of 20-minute, 30-minute infusions of daratumumab with well-tolerated and nice response rates. But what was reported at the last ASH meeting was a 3 to 5 minute subcutaneous infusion of daratumumab compared to this data. And what it showed was the subcutaneous administration resulted in actually a slower systemic absorption, but the maximal peaks and troughs of the agent were very similar to both the intravenous and the longer infusion rates. The safety profile was very similar. Low infusion-related toxicities, and it was a very well tolerated. And in fact, the subcutaneous dosing may even be associated with a higher response rate than either the intravenous or the longer pump-related subcutaneous infusion. So very promising, and I think coming relatively soon will be the subcutaneous administration of this agent. So CD38, SLAMF7, monoclonal antibody targets. The big emerging target is BCMA, the B-cell maturation antigen. This is a receptor for BAFF and APRIL expressed on plasma cells and some mature B cells and plasmacytoid dendritic cells. It seems to be responsible for the maintenance of plasma cell homeostasis. It's highly expressed on myeloma cells, and it seems to really promote the myeloma pathogenesis. So a very reasonable target. It doesn't seem to be on a lot of other tissues. The report, the first really, I guess, in a detailed report of using an anti-BCMA monoclonal antibody was in an immunoconjugate or an antibody drug conjugate, that where the antibody against BCMA is linked to a toxin, a very highly non-cell permeable, highly potent toxin that when it's floating in our blood, it's sort of like Mylotarg, right? So sort of like gemtuzomycin, ozogamycin. And it goes in, gets internalized, the linker pops off, and the toxin goes and does double-stranded DNA damage. And a report 2 years ago of the phase 1 trial showed that at the phase 2 dose, over 60% of the patients responded to this infusion of immunoconjugate, which is given as a short infusion every 3 weeks. So based on that, a larger phase 2 trial was presented at this last ASH, and it's still a small study, 35 patients, but these patients were heavily pretreated. 100% were exposed to the IMiDs and the proteasome inhibitors. About 40% had been exposed to daratumumab. 90% of these patients were refractory to the IMiDs and proteasome inhibitors, this regimen or this treatment was very well tolerated. Thrombocytopenia, anemia, hematologic toxicity was the primary toxicity, but there was an emergent other toxicity, an ocular toxicity, a reversible sort of corneal clouding that these patients had. To the extent that even though the study was designed to be given every 3 weeks, many of these patients had their drug held because of the corneal toxicity and received it only every 3 months. And it's a reversible corneal toxicity. Nevertheless, a 60% response rate in this heavily pretreated group of patients, with the majority of the responses being greater than VGPRs or greater. So very active BCMA targeted therapy. And for the entire group of patients, the median duration of response was about 8 months. And for the patients who responded, or I should say the first one was the progression-free survival, and of those who responded, they have not even met the a median progression survival. So very promising agent. There's other antibody drug conjugates that are under investigation with BCMA, with other toxins, anti-CD48, et cetera. Bispecific antibodies, such as like blinatumomab, are also under investigation in multiple myeloma. You know, these are antibodies that latch on to the T cell, activate the T cell, and then also latch on to a tumor antigen, BCMA, FCR, H5, SLAM-F7, CD38. These are all under investigation. But I want to spend the last bit of the talk talking about the cellular immunotherapies for myeloma. As you know, basically all of these therapies, except for the ones from Johns Hopkins where they're doing the marrow-infiltrating lymphocytes, most of these therapies, though, are simply pheresing the T cells from a patient with myeloma. Those T cells are ex vivo activated and infected with lentiviral or other viral vectors that insert into these cells genetic material to put on their surface, either a chimeric antigen receptor or an affinity-enhanced T cell receptor. These cells are then further enhanced and then infused into patients who have prior lymphopenia or received lymphodepleting therapy. And BCMA has been the primary target in multiple myeloma, as opposed to CD19, which of course is the FDA-approved regimens for ALL and non-Hodgkin's lymphoma. And this is just an example of the study at Penn that Adam Cohen led, where patients with relapsed and refractory multiple myeloma were treated in 3 cohorts. The first cohort actually, and this is one of the few studies that have done this, did not receive any lymphodepleting therapy at all, but just received these engineered T cells. The second cohort received cyclophosphamide as lymphodepleting therapy and then infusion of the T cells. but at a lower dose because it was a safety cohort. And then the third cohort gave the full dose of cyclophosphamide, the full dose of the cells in this group of patients. This was a 24-patient study. These patients are heavily pretreated, a median of 7 lines of therapy prior to it. You can see that virtually 100% of these patients were exposed to immunomodulatory agents, proteasome inhibitors, and daratumumab. Many of them were dual, quad, or penta-refractory. High percentage of these patients had very high-risk cytogenetics, and they had a high burden of disease, 70% involvement in their bone marrow. And this is the results in terms of response rates of the 3 cohorts. What's most remarkable to me, in the first cohort, we had responses. 50% of the patients responded, and most impressively is the patient who, within 4 weeks, went into complete remission and has remained there without any therapy for myeloma, despite having 11 prior lines of therapy and basically dying of myeloma. And that was 2.5 years ago, and he remains in complete remission. Nevertheless, the majority of those patients have relapsed. The cohort 2 study showed that it was safe to give lymphodepleting therapy in the infusion of cells. And then the cohort 3 shows that about 60% of the patients who received the full dose of the CAR-T cells have had nice responses, many of which are ongoing. This is not without toxicity, though. As you all know, the cytokine release syndrome is an aspect of this sort of therapy, and 90% of these patients did experience a cytokine release syndrome. Fortunately, all of them did just fine with them. And there was a dose-limiting toxicity. Neurotoxicity is another thing that you can see with these CAR-T cells, and we did have a patient who had a grade 4 press that we actually ended up treating with high-dose Cytoxan to kill the T cells, and that was successful in reversing it, and the patient did well. There are other studies of BCMA-related CARs. The Bluebird clinical trial, which included about 21 patients, showed a remarkable response rate of about 94% of those patients having a PR or greater, with about 56% of the patients going into complete remission. With follow-up of less than a year, though, patients are starting to relapse. So I think that impressive response rates, but we'll see how durable the responses are. And then, you know, from China, there was a report of 19 patients who were treated 100% response rate, 74% of the patients entering a complete remission. And again, with short follow-up, you need to really follow for the long-term response. Just as a comparison of these, they all use this co-stimulatory and stimulatory molecules of CD3 and the 4-1BB. What is a little different, and it's an important thing to keep in the back of your mind, is that for most of these studies, they required doing a test for BCMA expression, and only the high expressors were the ones who were treated. Actually, in the Penn study, we didn't do that. And probably that is something that we should do. And it does look like you need lymphodepleting therapy to really enhance the response. What's the best lymphodepleting therapy? Fludarabine cyclophosphamide has become probably the most common. There are other genetically modified T-cell approaches that you'll be hearing about. You can direct it against other antigens other than BCMA. NY-ESO is one that we've investigated and has shown activity in myeloma and other diseases. There's a really interesting approach called CART-Tyrin, where instead of using more of a classic antibody receptor, they have a different type of a novel antigen binding domain, but I think what's even more interesting about it, it doesn't use a viral vector to infect the cells. It's simply you incubate the cells with a plasmid that contains this genetic material, and the genetic material gets absorbed right into the cell. So very cool. And then, of course, we're always looking for an off-the-shelf product where you don't even have to take the T cells from the patient. And so an allogeneic cellular product would be very cool, though, of course, you have to do some sort of modulation of those cells so that you don't get rejection or graft versus host disease. Just to show you the data with the NY-ESO, the study that we've completed, which was 25 patients, infused these cells after an autologous stem cell transplant. So that clouds the results, but 70% of the patients had a beautiful response, and these patients stayed in remission. And these were all high-risk patients, and they stayed in remission for almost 2 years. There are studies going on now that are not using a transplant, but utilizing lymphodepleting therapy in the same way as the other things. So, to summarize, myeloma, immunotherapy. Initial therapy with proteasome inhibitors and immunomodulatory agents remains the initial immunotherapy that most patients will be receiving. The anti-CD38 monoclonal antibodies being used in combinations. Upfront regimens are being investigated, but obviously a major addition, and as you heard, potentially a maintenance therapy. The antibody drug conjugates are showing really impressive responses with low toxicity. Bispecific antibodies and for various other targets, and then of course CAR-T cell therapy seems to be, I think it's going to be the next approved area for hematologic malignancy. So thank you very much.